I'm Janency Ogisaka, a third-year nursing student of San Lorenzo Ruiz College of Roma. Today, I will be talking about two hematologic neoplasm diseases. So, there are a lot of diseases under hematologic neoplasm. But I decided to discuss the two subtypes of leukemia, which are the acute lymphocytic leukemia and the chronic lymphocytic leukemia. So before na ko explain everything about acute and chronic lymphocytic leukemia, let's tackle first what is hematopoiesis. So hematopoiesis is characterized by a rapid, continuous turnover of blood cells. So normally, the production of specific blood cells from their stem cells precursors is carefully regulated according sa needs sa ato body. If the mechanisms that controls the production of these cells can disrupt, so the cells can proliferate excessively as seen in the development of hematologic neoplasms. Leukemia. Leukemia is a neoplastic proliferation of a particular cell types like granulocytes, lymphocytes, or infrequent erythrocytes or megakaryocytes. The defects originate in the hematopoietic stem cells, the myeloid, or the lymphoid stem cells. So the leukemias are classified according to the stem cells line involved, either lymphoid, referring to the stem cells that produces lymphocytes, wherein I will be discussing later, or the myeloid, referring to the stem cells that produces non-myeloid blood cells. So leukemias are also classified as either acute or chronic. In leukemia, we have four types, which are the AML, or the acute myeloid leukemia, and the chronic myeloid leukemia. We also have the acute lymphocytic leukemia and the chronic lymphocytic leukemia. So in this video, I will be focusing on the ALL and CLL, or the lymphocytic leukemias. So, acute lymphocytic leukemia results from uncontrolled proliferation of immature cells derived from the lymphoid stem cells. So, ALL is most common sa young children, with boys affected more than often than girls. So, peak incidence ani is 4 years of age. After 15 years of age, it is relatively uncommon until age 50 when the incidence again rises. Immature lymphocytes proliferate in the marrow and impede the development of normal myeloid cells. As a result, normal hematopoiesis is inhibited, resulting in reduced numbers of granulocytes, erythrocytes, and platelets. So these are the signs and symptoms of ALL, or the acute lymphocytic leukemia. Includes gum bleeding, pain from an enlarged liver or spleen, and even bone pain. So patient may also exhibit cranial pulses or even headache and vomiting because of meningeal involvement. And we have different medical and nursing management to treat ALL, or acute lymphocytic leukemia. Preventive and topical chemotherapy and cranial irradiation is a key part of the treatment plan because ALL frequently invades the central nervous system. And even hematopoietic stem cell transplantation, or HSCT, is a treatment for ALL. It can improve long-term disease-free survival. However, this benefit must be weighted with the risks associated with the procedure, including death and long-term morbid complications. Next disease is the chronic lymphocytic leukemia. CLL is a common malignancy of older adults and the most prevalent type of adult leukemia in the Western world. It is rarely seen in Native Americans and infrequently among persons of Asian descent. Unlike other forms of leukemia, a strong familial predisposition exists with CLL. The disease can occur in 10% of those with first or second degree relative with the same diagnosis. Pathophysiology of CLL. CLL is typically derived from a malignant clone of B lymphocytes, formerly called T lymphocyte CLL. CLL is rare and now reclassified as T-cell prolymphocytic leukemia. Most leukemia cells in CLL are fully matured. One possible mechanism that explains this oncogenesis is that these cells can escape apoptosis, or what we call the programmed cell death, resulting in excessive accumulation of the cell sa ato bone marrow and sa ato circulation. Because the lymphocytes are small, they can easily travel through the small capillaries within the circulation. When it takes less than 12 months for the absolute number of lymphocytes to double, a more aggressive disease course may ensue. These are the signs and symptoms of CLL, or the chronic lymphocytic leukemia. Many patients are asymptomatic and are diagnosed and incidentally during routine physical examination or during treatment for another disease. Increased lymphocyte count is always present. There will be an enlargement of lymph nodes, or what we call the lymphadenopathy, and it can be severe or sometimes painful. Spleen can also be enlarged, or the splenomegaly. Patients with CLL can develop B symptoms, a constellation of symptoms including fever, sweats, especially at night, and unintentional weight loss, and also fatigue. And we have different medical management to treat CLL, or chronic lymphocytic leukemia. Patients with no symptoms at the time of diagnosis, the traditional watch and wait approach is still used. Other management is chemotherapy. Next is the medication. The effectiveness of conventional treatment must be balanced by the risk of toxicity. For example, the chemotherapy drugs fludarabine and cyclophosphamide are often given in combination with the MOAB rituximab. And that's the end of my discussion. Thank you so much for watching, and I hope you learned something from me. Bye bye.